Have you ever looked at, really complex medical research, maybe some dense paper, and just wish someone could boil it down for you?
Uh-huh.
Cut through all the jargon, pull out the key bits, and just explain what it really means for actual people.
Yeah, that's exactly what we're trying to do today. We're taking a deep dive into a recent pooled analysis. It brings together two big clinical trials, Checkmate 227 and Checkmate 9LA.
Okay.
And we're zeroing in on a specific group, often kind of overlooked, actually. Patients with metastatic non-small cell lung cancer, that's NSCLC, who have really low levels of a biomarker called PD-L1.
Right, the PD-L1 less than 1% group.
Exactly, less than 1%. So this whole deep dive is about figuring out what these pretty remarkable new findings mean for their long-term survival and, their quality of life.
Okay, let's set that up a bit more. So non-small cell lung cancer. It's the most common type of lung cancer, right?
That's right.
But we're really focusing in here on the subgroup. Metastatic NSCLC PD-L1 expression under 1%. And you said this group is important. Why is that exactly?
Well, historically, they've faced particularly tough prognosis, a real high unmet need.
Okay.
The usual treatments, like single immunotherapies or even adding chemo, they often just didn't give great long-term results for this specific group. So yeah, finding a better path forward has been, well, really difficult.
Gotcha. So difficult group needs better options.
Precisely. And that's where these two drugs come in, working together, Nivolumab and Ipilimumab.
Nivo and Ipi. Yeah. Heard a lot about those.
Right. So Nivolumab is an anti-PD-1 immunotherapy. Ipilimumab targets something different, CTLA-4. Think of it like the immune system has multiple breaks that cancer can use to hide.
Okay.
Nivolumab releases one break on the T cells, letting them attack. Ipilimumab releases a different break, so using both together, it's like taking off two separate breaks, really revving up the immune response.
A kind of double boost for the immune system then.
Exactly. And what's really interesting for this group, the low PD-L1 group, is that ipilimumab might actually help increase that PD-L1 expression a bit and just generally wake up the T cells more effectively. So the combo could be especially helpful here.
That makes sense. And bringing together the data from two big trials, Checkmate 227 and 9LA, that gives you a lot more power, right? A longer view.
Absolutely. This pooled analysis isn't just a snapshot. It's looking at the long-term picture from these large randomized studies. It really lets us see the full impact.
Okay, so let's get into that impact, the results. What did this analysis actually show for patients?
Right, the crucial part. So let's look at the overall group first, everyone, with tumor PD-L1 less than 1%. We're comparing nivolumab plus ipilimumab, sometimes with a couple cycles of chemo, sometimes without, versus just chemotherapy alone.
Okay, the head-to-head.
Yeah, and the big one, overall survival, or OS. The median OS for the Nivo-Ipi group was 17.4 months.
15.4, and chemo alone.
Just 11.3 months, so a pretty significant difference there.
Wow, yeah. Over 6 months difference in the median. That's substantial.
It is, but what's maybe even more striking is the long-term picture, the 5-year OS rates.
Okay.
For the Nivo-Ipi combination group, it was 20%. 20% of patients alive at 5 years.
20%, and for chemo?
Only 7%.
7, wow. So 20 versus 7% at 5 years? That really speaks to a durable long-term benefit, doesn't it?
It absolutely does. It suggests this isn't just delaying things slightly. It's potentially changing the long-term trajectory for a meaningful number of these patients, giving them that chance for, real long-term survivorship.
That's huge for a group that, as you said, had such limited options before. It's giving back time, really.
Exactly. And other measures point the same way.
Yeah.
Progression-free survival, PFS, that's how long until the cancer starts growing again. The median was 5.4 months for the combo versus 4.9 for chemo.
Okay, median difference isn't huge there initially.
No, not the median.
Yeah.
But look at the 5-year PFS rates, 9% for the combo versus 2% for chemo. So
Yeah.
again, that long-term control is better.
Right, keeping the disease stable for longer.
Yeah. And response rates were higher too. Objective response rate, ORR, was 29% versus 22%. So more patients saw their tumor shrink.
Okay.
But here's another really impressive one. Duration of response, DOR. How long do those responses last?
Right, because shrinking is good, but you want it to last.
Precisely. The median DOR for the Nivo-Ipi group was 18 months.
10 months compared to...
4.6 months for chemotherapy.
Wow, almost a year and a half versus less than 5 months. That's incredible.
It is. And get this, at 5 years, 25%, quarter of the people who responded in the immunotherapy group were still in response.
Still responding 5 years later.
Yeah, compared to only 2% in the chemotherapy group. That really highlights the durability.
That's truly remarkable. Okay, so the overall picture is strong, but what about those subgroups? You mentioned patients with, say, brain metastases or certain tumor types who often do worse. How did this combo perform for them?
That's a really critical question because
Yeah.
these are often the toughest cases, the highest unmet need within this already challenged group.
Right.
So let's take patients who had brain metastases when we started treatment.
Mm-hmm.
For them, the median OS with Nivolumab was 17.4 months. Same as
Oh,
the overall group, actually,
okay. And with chemo?
just 9.2 months.
Yeah.
And the 5-year OS, 6% with a combo
Mm-hmm.
versus 0% with chemotherapy.
0% at 5 years with chemo if they had brain mets. Wow.
Yeah. And what's interesting is the magnitude of benefit seemed even greater in this brain met subgroup compared to those without brain mets, probably because chemo just doesn't work very well for those patients.
So the immunotherapy combo is really stepping up where chemo falls short there.
It seems so. And another tough group,
Yeah,
patients with squamous NSCLC. It's often more aggressive.
right.
There, the median OS was 16.2 months with Nivolumab versus 8.2 months with chemo, and the 5-year OS rates, 21% versus 5%.
Again, a huge difference, 21% versus 5%.
Yeah.
So for these really difficult to treat populations, this seems like a major step forward.
It really does appear to offer a significant advance for these specific subgroups who've had such poor outlooks historically.
Okay, that's efficacy. But what about, living with the treatment side effects? And what happens if someone has to stop treatment early? Does the benefit just disappear?
Great questions. Let's talk about side effects first. About 21% of patients in the Nivolumab arms had to stop treatment because of treatment-related adverse events, or TRAs.
Okay, about 1 in 5. That sounds potentially concerning. Did stopping hurt their survival?
Well, here's a really compelling finding. For those patients who did stop due to TRAs, their median OS was actually 35.4 months.
Wait, higher, 35.4 months.
Yes, and their 5-year OS rate was 37%.
37%. That's much higher than the overall group rate of 20%. How does that work?
It's fascinating, isn't it? It strongly suggests that discontinuing because of these side effects, it didn't seem to negatively impact their overall survival compared to the whole treatment group. It might even imply that the immune system, once activated, can continue to provide benefit even after stopping the drugs, perhaps particularly in those who had a strong enough response to also get side effects.
That's counterintuitive, but really encouraging. What about those who finished the planned treatment?
Good point. About 10% of patients completed the full 2 years of immunotherapy. And the data shows they also continue to experience prolonged clinical benefit well after stopping treatment.
So sustained benefit seems possible both for those who start early due to side effects and those who complete the course. That's reassuring. What about the overall safety profile? Any new alarms?
No, the pooled analysis confirmed that no new safety signals popped up. The kinds of TREs seen were generally what we expect with these drugs. Things like diarrhea, nausea, fatigue. They were mostly manageable.
Okay. Were there serious side effects?
Yes, about 28% of patients on the Nivolumab arms experienced serious TRAs. But it's important to note the rate of treatment-related deaths was actually low 1% in the immunotherapy arms compared to 2% in the chemotherapy arm.
Okay, so manageable profile for many, serious events in some, but low rate of fatal events. That context is important.
Absolutely. Now, stepping back, why are these findings so important in the bigger picture of treating this low PD-L1 NSCLC?
Right. How does this stack up against other options out there?
Well, this is where it gets really interesting. If you look at other immunotherapy regimens, maybe like pembrolizumab or edzolizumab, often given with chemotherapy but without that second drug, the CTLA-4 inhibitor like Ipilimumab.
Okay, the PD-1 or PD-L1 inhibitor plus chemo combos.
Exactly. For patients with this low PD-L1 expression, those regimens generally showed, well, less impressive results. Often described as suboptimal or moderate improvements in OS, sometimes no clear improvement at all compared to chemo alone in this specific subgroup.
So they didn't provide that same big survival jump for the less than 1% group.
Generally, no. For example, data pooling Keynote 189 and 407 showed a 5-year OS around 12.5% for pembrolizumab plus chemo in PD-L1 low patients.
Okay, 12.5% versus the 20% you mentioned for Nivolumab.
Right. And even nivolumab plus chemo in Checkmate 227 only showed a 10% 5-year OS in this group.
So Nivo plus chemo didn't do as well as Nivo plus CP for this group?
Correct. The data really seems to point towards the addition of that CTLA-4 inhibitor like Ipilimumab being key to driving that consistent long-term OS improvement, specifically in patients with PD-L1 less than 1%.
That dual immunotherapy approach seems crucial then.
It really does.
And you mentioned something earlier about consistency.
Yeah.
How did Nivo-Ipi do in this low PD-L1 group compared to how it did in patients who had higher PD-L1 levels in the same trial?
Yeah, this is another striking point. The median OS for Nivo-Ipi in the PD-L1 less than 1% group was 17.4 months, right?
Right.
Well, in the same trials for patients with PD-L1 1% or higher, the median OS with Nivo-Ipi was very similar, 17.1 months in CheckMate 227, 15.8 months in CheckMate 9LA.
So the benefit was pretty much the same whether PD-L1 was low or high.
Exactly. It suggests that for this particular dual immunotherapy combination, the effectiveness, at least in terms of median OS, seems remarkably consistent regardless of the patient's tumor PD-L1 expression level.
That kind of challenges the whole idea that PD-L1 level predicts benefit for this specific combo.
It does seem to decouple the benefit from the biomarker level for Nivo-Ipi, which is quite different from what we see with PD-1, PD-L1 inhibitors used alone or just with chemo.
Fascinating.
So wrapping it all up, these findings really bolster the case for using Nivolumab plus Ipilimumab, either with or without those initial chemo cycles, as a key first-line option. It offers that chance for genuine, long-term, durable clinical benefit for this population that historically just hasn't had many great choices.
This deep dive really paints a picture of, well, significant progress. For patients with low PD-L1 NSCLC, this isn't just a small step. It's offering a real chance at long-term survival that was much harder to imagine just a few years ago.
It truly is. And it leaves us with a really interesting thought to ponder, doesn't it? Seeing how effective this dual immunotherapy approach is for a group traditionally seen as less likely to respond based on PD-L1, how might that change our whole approach? Does it push us to think beyond just PD-L1? What does it mean for finding maybe even better biomarkers, more precise ways to understand each patient's specific cancer and immune system so we can perfectly tailor treatments and give everyone the best possible shot no matter what their initial profile looks like?